So this is something probably a lot of you don't know about. And actually, I thought this was a data talk. I didn't know it was a case because you wrote emerging data in the title. So it's going to be some data, but I will show you why we need this with a bad case. My disclosures. You saw some nice STEMI cases with short door to balloon times by Samir. But despite that, we do a really pretty poor job in salvaging myocardium. And this is data from Horizons AMI, where we did baseline and follow-up angiograms at 13 months. So we did acute angiograms prior to the STEMI PCI. And we look at the global improvement in left ventricular ejection fraction. And in about 60% of the cases, there's actually no change or reduction in the ejection fraction. And when there is a change, it's like a 0.5% improvement on average. And so let me show you. This is the problem. Oops. Forward. This is the problem. So poor recovery of LV function in patients without cardiogenic shock is really the number one issue we have in primary PCI today. So here's a 49-year-old man who presented with crushing chest pain for 90 minutes. So reasonably rapid time, he ended up in the emergency room. And here's his baseline angiogram. Total thrombotic occlusion of the proximal LAD before the first septal perforator. And here's his baseline left ventriculogram. And I still do baseline LV grams and recommend this before all procedures. It's really, really helpful. Occasionally you'll find VSDs or other mechanical complications of AMIs, aortic dissection. You'll understand what the left ventricular end diastolic pressure is. And as long as the renal function is not too bad, it takes 5 minutes. And you can see his whole anterior wall is not moving, apex is not moving, distal inferior wall is not moving, slightly dyskinetic at the apex, etc. Okay, so his door to balloon time is 67 minutes. Okay, so not too bad. And here's the post-PCI result. You get great TIMI-3 flow. You can see the stent and the proximal LAD. And we brought him back at 13 months. He was in the study, so for routine follow-up angiography, stent is widely patent, TIMI-3 flow, no side branches are missing or anything. And so remember, here's his baseline LV gram before we did the primary PCI, and here's his LV gram 13 months later.
But Gregg, following your teaching of the blush, how do you feel about the blush?
Right, exactly. So we get the epicardial coronary artery open, very high rate, 85 to 90% TIMI-3 flow after primary PCI. But as I'm going to show you in the next slide, we only restore myocardial reperfusion in about half those cases. And as a result, we only get normal ST segment recovery in about 50% of cases. So, I mean, look at what happened to this patient. This patient ended up in NYHA class 2 heart failure. And you can see some thrombus actually at the apex. And his ejection fraction didn't improve at all. In fact, it went down a little bit because he doesn't have the compensatory hyperkinesis at the base anymore. So this is really our biggest problem. And we and others have shown from this large pooled analysis of infarct size measured within 3 to 5 days after the infarct and then 1 year outcomes, that there's a hugely powerful relationship between infarct size and non-shock patients and both death and heart failure rehospitalization rates. And again, this is just what we were talking about. If you look at TIMI-3 flow, this was from Horizons, 86% in all cases. This was 3,600 patients, not bad. But myocardial blush is normal in only 51% of cases, and ST segment resolution is only complete in 50.5% of cases. So we should be honest with ourselves. In about half the cases, we're not successful with primary PCI, even though we get the artery open, and that confers a survival advantage. It adds electrical stability, it prevents aneurysm formation, other things, but it does not afford myocardial recovery. So the concept of supersaturated oxygen was to basically withdraw the patient's own oxygen from the femoral artery after the procedure, once you've got the coronary artery open, so it doesn't delay reperfusion at all, put it into an oxygen mixing chamber and pump it up. Pump patient's own blood up to 760 to 1,000 millimeters of mercury of oxygen, and then reinfuse it into the coronary artery. And initially, we did this through a tracker-type catheter right into the coronary artery zone of the myocardial damage. And this basically was trying to replicate wound healing, what was done in hyperbaric chambers. And believe it or not, there were some early studies where they put STEMI patients in hyperbaric chambers. And there was actually early data in about 29 patients that myocardial recovery was improved. but it's not really reasonable to put a STEMI patient into a hyperbaric chamber. So the concept here is that you're actually infusing the damaged tissue with hyperbaric oxygen at very high partial pressures of oxygen, similar to what would be done in a hyperbaric chamber. And a lot of this work was done by Richard Spears in Detroit, and he showed in animal models that, after 60-minute animal occlusions where you get these transmural infarcts, if you then do the 60-minute occlusion and then infuse supersaturated oxygen, you essentially eliminate the infarct. A lot of basic science data, but I won't show you that now. So we ran a randomized trial called AMI-HOT2, and this is a pivotal trial that was designed to show reduction in infarct size, and it was actually a positive trial. This is the only positive trial of any therapy so far, a pivotal, adequately powered trial to show reduction in infarct size. So this was all in LADs, proximal and mid occlusions of LADs, TIMI 0 to 2 flow at baseline, patients presenting within 6 hours. And you can see the control infarct sizes were 25% of the left ventricle, and that was reduced by supersaturated oxygen to 18.5% of the left ventricle. This was a Bayesian study. It was highly positive, and the median of the differences was 6.5% of the left ventricle. That would be expected with a couple thousand patients to translate into about a 25% reduction in mortality.
And Greg, the baseline size of the MI was similar in both groups?
Yeah, similar in both groups, about 25%. Well, this, again, we didn't know. There was no baseline. We just had a 3 to 5 day measure of infarct size because these are primary PCIs. The problem with supersaturated oxygen, we initially had some safety concerns. The overall MACE rates were not significantly different, and in fact, we easily met the non-inferiority criteria for safety. But there was some extra bleeding because, again, this was all done from the femoral artery, and you needed to use a larger catheter or a second stick to draw the patient's own blood, and that led to some increased local vascular bleeding complications. And so FDA wanted us to come up with a better technique, or wanted the company, which is Therox, to come up with a better technique that was a little safer. And so this process was then turned into what was so-called optimized supersaturated oxygen, where basically after the PCI, the supersaturated oxygen is just given through a diagnostic catheter at the origin of the left main. So now it infuses both the LAD and the circumflex artery, and the infusion rate was increased, and the time of infusion was decreased from 90 minutes with the old way to 60 minutes. So this is a 60-minute infusion. But basically now that you're doing it through a diagnostic catheter, the sheath can be substantially smaller. And we did basically 100-patient safety study, and the FDA wanted to see a performance goal of all these different MACE events at 30 days of less than 10.7%. That was based on literature and propensity matched patients, and we were at 7.1%. In fact, there were only a few TIMI minor bleeds. There were no TIMI major bleeds, and there were no. The incidence of target lesion failure was only 1 patient, or 1%. So on the basis of this, and then we had this was not a randomized trial, this secondary study, but we did a propensity matched analysis compared to the Infuse AMI trial, which was done at close to the same time, exact sorts of patients. And in Infuse AMI, which didn't use supersaturated oxygen, we had a 12.3% incidence of death or new onset heart failure hospitalization at 1 year, compared to 0% in these 100 patients. Not randomized, so take it with a grain of salt, but promising. And you can see the reductions were in death and heart failure, with no differences in myocardial infarction, TVR, or stent thrombosis, and you wouldn't expect differences from this therapy. So the bottom line is that on April 2nd of 2019, the FDA approved supersaturated oxygen therapy for the treatment of patients with anterior MI undergoing primary PCI within 6 hours of symptom onset. And it's now readily available for you to use in your cath labs. Again, right now we recommend it only in anterior myocardial infarctions with angiographically proven proximal or mid-LAD TIMI 0 to 2 flow at baseline within 6 hours, then a successful PCI result. TIMI 2 or 3 flow post-PCI. This isn't the last you'll see of this. The company's supporting a post-approval randomized trial in 434 patients to replicate the reduction in infarct size and using a composite hierarchical and clinical endpoint to show reduction in all-cause death, heart failure hospitalizations, or infarct size. And we're also now exploring this in shock. So there's a randomized ISO-shock trial, which is just starting, which will be a 60-patient randomized trial looking at supersaturated oxygen in shock. So anyway, this is a new therapy. It's the only one approved right now, and the only one that's been shown to reduce infarct size. And I think it's very reasonable to consider in these very large infarcts without shock at baseline that still have a high rate of death and heart failure hospitalization despite timely primary PCI. Thanks. I'll stop there.